Dear friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Jani, and our guest for today is Dr. Mary MacDonald. She is a vascular surgeon at Thunder Bay Regional Health Science Center. Today we are going to talk about some of the common vascular disorders like peripheral vascular diseases, aortic aneurysm, and many of them do need a surgical intervention. If we don't treat them, they can be fatal or increase the mortality or morbidity. So today Dr. Mary MacDonald is going to guide us about how to prevent and how to treat the vascular disorders. Thank you, Dr. MacDonald, for coming to the show.
Thank you, Dr. Jani.
I know you are very busy at the hospital and still you took out the time and coming here, so that's really appreciated. Please tell us about the role of a vascular surgeon. What does a vascular surgeon do?
A vascular surgeon is a surgeon who does blood vessel assessments, blood vessel surgeries, and interventions that are minimally invasive as well. So we offer essentially the full suite of vascular medicine. When we think about vascular, we think about arteries, which carry blood from the heart out to the periphery, and veins, which carry blood back. The bulk of the disease is in the arteries, but we certainly do vein interventions as well. We do assessments. I do a lot of assessments for people who don't require surgery. We also do angioplasty, minimally invasive procedures, and of course open surgery, as you usually think of with a surgeon.
So vascular surgeon is same as cardiovascular surgeon?
Good question. So today's vascular surgeons assess and intervene on blood vessels that are outside the heart and outside the brain. Neurosurgeons would deal with blood vessels inside the brain, and cardiac surgeons, which are their own specialty, would deal with cardiac blood vessels, coronary arteries.
Okay, and rest of
So we do everything else.
Right.
Yeah.
So in Thunder Bay or in Northern Ontario, what sort of disorders are you commonly seeing in your day-to-day practice?
We very commonly see poor circulation, which is arterial disease, narrowings or occlusions in the arteries to the legs. This comes along with an older population, a high rate of smoking, a high rate of diabetes, and high blood pressure. And Northwestern Ontario does have a high rate of all of those underlying risk factors, and we see it as people enter their 60s, 70s, and 80s with decreased mobility.
So all those patients, they have the vascular disorders involving arteries of extremities.
Yes.
So what happens in these arteries? They become narrow, or what happens in them?
They do become narrow. What happens is over many years or even decades, they get deposits of cholesterol, calcium, sometimes some blood clots or thromboses, and these will collect in the arteries, especially at branch points, and cause them to narrow over time or even to block off. To a certain extent, a person's body can compensate. The smaller branches will become larger, and that will help for a while. But as you get older, if you get more and more narrowings and blockages, eventually that'll affect the ability to walk.
So what happens when the artery is narrowed down in the extremities? A patient gets pain or mobility problems or swelling, or what happens to them?
Initially, there's no symptoms, which is what makes it so insidious. But after a while, a certain percentage of patients, about 10%, will find that their muscles get very sore after a short distance of walking. When they're at rest, they're generally pain-free, but the moment they start to walk, their muscles get poor oxygenation because the arteries that carry oxygen are narrowed, and after a few minutes of walking they find that it's too painful to continue.
So how many patients of this you see every day in Thunder Bay?
Oh, I see about 25 to 30 patients
Every
in my
single
weekly
day?
clinic. Yeah.
With the peripheral vascular diseases?
Many have
that's
peripheral
too many
vascular
numbers.
disease. Yeah, it is a high number. Not
So-
all of them need an intervention, but I certainly will see them and follow them along.
And the risk factor is diabetes and smoking. Is that the predominant, or lifestyle related, like lack of exercise? Or
There are a few that are inherent. So being male is one, being older than age 50 is another. There's not much you can do about that. It's a little bit familial, but so common that you can't really say it's carried in a certain family. And then the risk factors that are modifiable that people can address would be high blood pressure, smoking, and diabetes or good diabetic control.
So, as a complication of this blockage of the vessels of the extremities, which is called peripheral vascular disease,
Yes.
what happens? What are the manifestations if you don't treat it?
If you don't treat it, there are two things that we're very concerned with. First is the effect on mobility. When the muscles don't get enough oxygen, folks can't walk for longer than a few minutes.
Yeah.
And if unchecked, it can carry on to be constant pain, and at the worst extremes, perhaps 1% of people will actually develop dead or dying tissue on their feet, sores or ulcers. The second thing to consider is that all those risk factors are the same risk factors for heart disease.
Yes.
And so some people with peripheral arterial disease will actually go on to develop heart attack or stroke. And so control of those risk factors is important both for preserving mobility but also for preventing
Heart disease
cardiac
as well.
death. Yeah.
So how do you diagnose it? Somebody has a pain, he goes to the family doctor and then
Yes.
it is referred to the surgeon, or how does that happen?
Exactly like that. So generally people will see their primary care practitioner if they get pain. Primary care practitioners are also very good at prevention. So they will do things even early on, like screening blood cholesterol, recognizing that someone's diabetes needs good control, counseling for smoking cessation. And those are really important in the early stages, and probably for the vast majority of people that would be sufficient. If it gets to the point where someone's walking is severely impaired, generally we'll get a referral. And then we can do imaging to show exactly where the arteries narrowed or blocked, discuss with the patient control of their risk factors, but also perhaps whether an intervention is required to get them walking again.
So what sort of surgical options are available for them?
We think of it in two broad senses. One is traditional open surgery, where we would either clean out the artery, that's called an
So you open the leg muscles and
open up the
artery?
Open up the artery, usually in the groin, sometimes down the leg.
Okay.
Clean it out, that's called an endarterectomy. And we actually take out pieces of calcium and cholesterol that you can see. We send it to the pathologist.
We get it, yeah.
Yeah, exactly. And then we close the artery with a patch, and the patch is a leather-like patch that widens it a little bit. The other would be a bypass, where a long blockage is bypassed, and we usually
Put a
use
graft or something
the
like that?
patient's own vein or a graft that we can purchase. Yeah.
Perfect.
The other is minimally invasive angioplasty, and so some folks may have experience with angioplasty and stenting in the heart vessels, but we can do that in the periphery as well.
Perfect.
And here in Thunder Bay, both the interventional radiologists and the vascular surgeons do those cases. We plan them together, we do them together.
That's very good.
Yeah.
We'll continue our discussion. We'll take a short break and we'll continue the next part.
Thank you.
Please stay back for the next part. Thank you. Welcome back to the show, Talk with Your Doc. I'm Dr. Prashant Jani, and our guest for today is a vascular surgeon, Dr. Mary MacDonald from Thunder Bay Regional Health Science Center. Thank you, Dr. MacDonald.
Thank
so
you.
please tell us about the endoscopic surgical option, like a grafting option.
Yes. So in some people, the anatomy is favorable for stenting rather than a full open surgery. Generally, if they have a short lesion or a narrowing rather than a complete blockage, what we can do is, as a day procedure, bring them into the radiology department, and with our radiology colleagues, we plan and do a day procedure. We access one of the arteries with a little puncture needle. We place a plastic sheath, which is a lot like an IV cannula, a plastic tube, a little bit bigger. And through the sheath, once that's placed, we can introduce wires and catheters past the
deep
blockage.
inside.
Exactly. And just like with the heart arteries, tiny, expensive balloons to widen out the artery. And if that's not quite enough, then we also have stents.
Yeah.
Once that's done, folks are on a blood thinner, an aspirin or something similar called Plavix, for a few months. Generally, they notice the benefit right away, and we do keep an eye on that going forward
So when you pass that catheter or cannula inside with that plastic tip, does it rupture the plaque or the blockage, or what does it do actually?
When the artery is hard or calcified, and the term hardening of the arteries is appropriate, it tends to narrow with a calcified rim. If you can crack that rim with the balloon, the elastic properties of the artery will sort of take over and the blood will flow a little bit better.
Okay.
So we go inside the artery, we crack that calcified rim, and we allow it to heal wider than previous.
What are the complications of this endoscopic approach?
As with any invasive procedure, bleeding would be probably the main complication that we would watch for, be concerned with. It does happen from time to time, we've all seen it, but generally we can control it.
But most of the patients recover?
Yes.
You say it's a day surgery, so no need of admission?
Correct.
Like overnight and just come in the morning, go back home in the evening?
Exactly.
Yeah.
Yeah.
And then what are the precautions one should take after the surgery, like mobility options?
Usually we're concerned with the site that we punctured. So we get the patient to lie flat for 4 hours after the procedure inside the hospital. Their nurse will then walk them around, check that site again. It's often the leg, sometimes the arm. And if that looks good, they can go home. If there's any concern about excessive bleeding, keeping in mind that we're using blood thinners at the same time, then we keep them overnight.
If somebody doesn't want to do surgery, is there any medical treatment options for the blockage of the vessels of the legs or extremities?
There's currently no medical treatment if the blockages or narrowings have already occurred, but that's why prevention is so important.
Yes.
And so we use things like Crestor or Lipitor, the statin medications.
Statins will reduce the cholesterol in your body.
Exactly, to reduce the cholesterol, and good blood pressure control, good diabetic sugar
Yes,
control.
And of course, no smoking and controlling the dietary lifestyle.
Exactly. Smoking cessation is
That's a predominant risk factor for the vascular diseases, right?
It is. Especially ongoing smoking. If people are able to quit smoking, it's worth mentioning that the arteries do benefit. And so in as little a time as 6 weeks, you can see and feel improvements in the arteries. And at about 2 years after smoking cessation, the arteries respond very similarly to people who have never smoked. So there's real gains to be made if people are able to stop
They
smoking.
become normal probably.
Almost normal with respect to the arteries, yes.
Perfect, yeah.
Yeah.
So in addition to the peripheral vascular diseases, what other treatments, what other diseases you treat?
Predominantly we see diseases in the aorta,
Aortic vessels?
and that would be an aortic aneurysm. We also see some disease in the carotid arteries, which can lead to a risk for stroke. And we help with dialysis access. So people who require dialysis for kidney disease, we often create fistulas for them.
Okay.
Yeah.
So let's talk about aneurysm. How common is it to one have aneurysm?
In the overall population, it's about 1 in 100, so uncommon. But when you look at men over age 50, it's about 1 in 20.
Oh,
Yeah.
1 in 20. That's just like a
It's pretty common, in that age group, yes.
Yeah. So what is aneurysm?
An aneurysm is an area of the vascular wall, the arterial wall, that has become weakened over time. When we think about aneurysms that form spontaneously, we think it's related to a little bit of a breakdown in the muscle and the elastic tissues of the aorta over time.
So in aneurysm, what happens? Like the artery becomes big, or there's a pouching of the artery, or what happens?
Exactly. So I'm going to discuss the aorta, which
Yeah.
is the major blood vessel in the body,
Yeah.
and that's usually about 1.5 to 2 centimeters in diameter.
And that's the aorta here.
That's the aorta there. It arises from the heart, and
Yeah.
it's the main artery from which all the other branches arise.
Yeah.
So an aneurysm is an area that's weakened. It
Yeah.
has a distinct start and an end point. Here's a second one there.
Yeah, so these are two outpouchings of the artery here.
Exactly.
So it becomes dilated.
It becomes dilated. Generally, we say that if it's 1.5 to 2 times the normal size, and if it has a distinct starting and ending point, that's considered an aneurysm.
Okay, so this entire area is aneurysm, and there are 1 and 2 parts of it.
Yes.
And what is this here?
within the aorta, the blood flow will actually go out to the sides of the aneurysm initially, but over time, that blood will often become stagnant. So these are clots.
Clots, okay. So these clots are not good, right?
They're generally not good,
They
no.
they can dislodge and go to any other parts of the body then?
They can. They can. In an aortic aneurysm, that would be a little bit rare because the flow is so brisk, but it becomes more of a problem if the aneurysm is elsewhere, for example, in the leg.
So who gets this aneurysm?
Generally
Anybody?
speaking, it could be anybody, but when we think about aneurysms that form because the tissue is breaking down a little bit, it's the age over 50 that we're most concerned with. They're 4 times more common in men compared with women, and the other risk factors are high blood pressure, smoking, and family history.
Increased cholesterol, does it risk the aneurysm risk?
Interesting. So there's no direct connection between increased cholesterol and aneurysm formation. However, the statin medications that we use to treat cholesterol have an aneurysm stabilizing effect.
Okay.
So they're good for that purpose as well.
And how about smoking and aneurysm?
Yeah, smoking is a risk factor
Risk
for
factor of
aneurysm
aneurysm.
formation. Yeah.
So what happens, like say this is big, like say 2 centimeter or 4 centimeter or 5 centimeter, what are the risk factors of size and the aneurysm and death?
Exactly.
Can somebody die with the aneurysm?
They can. So the aneurysm itself doesn't change the function of the artery. You still get blood flow through the artery. The concern is that as that aneurysm increases in size, the blood vessel wall thins.
It becomes very thin.
It becomes
and can't
thin, just like
withhold
a
the
balloon.
pressure.
Exactly. So the larger an aneurysm is, in general terms, the higher the risk that it will actually bleed or rupture.
And die.
Exactly. So
Wow, that's a fatal complication.
exactly. Yeah.
We'll take a short break and we'll continue our discussion on the treatment options of this.
Thank you.
Please stay back for the next part. Thank you. Welcome back to the show, Talk with Your Doc. Today we are talking about vascular surgeries, and Dr. Mary MacDonald is guiding us very nicely. Thank you, Dr. MacDonald. So, does this aneurysm runs in the family? Is there family history runs a risk factor?
Yes, that's a risk factor. It's not 100%, but they are to some extent familial. So what we would do is, if the aneurysm is found, and that could be by examination, often by a family doctor or primary health practitioner, or often these days an imaging, for example, a CT scan that's done for another reason, will reveal an aneurysm.
So, as you say that this aneurysm can rupture and somebody can die.
Very true.
But if somebody has aneurysm and he has no symptoms, and I might have and I don't have any symptoms.
That might be true.
True.
They tend to be asymptomatic, hence the importance of finding them on examination or with imaging. What we've done in Canada and in Ontario in the last 2 years is to enact screening guidelines. So I'd like to talk about those for a moment.
Yeah.
So we know they're associated predominantly with male gender and with advancing age. So currently in Ontario, there's a new 2019 recommendation that men between the ages of 65 and 75 or beyond, if they're healthy, be screened with an ultrasound for an abdominal aortic aneurysm.
So it's just a regular ultrasound test, like half an hour test probably?
Exactly. It's a regular ultrasound test. They look predominantly at the aorta, right in the abdomen below the renal arteries, because that's by far the most common place for an aneurysm to form. And if they have one, then we check every other artery.
Okay.
Once the patient reaches that age, we also look at the other risk factors. So people with a family history should be screened. Women with risk factors such as smoking or family history should be screened. And it's in that 65 to 75 age group that we see most of them. Yeah.
So suppose somebody has aneurysm. What are the treatment options for them? What should they do to minimize the risk of rupture?
Well, the first thing would be to control their risk factors. So good blood pressure control, smoking cessation if possible, and of course they can't do anything about age or gender. When the aneurysms are small, so an aneurysm that's maybe only twice
Small.
the size of the aorta, they're generally considered very stable.
Okay, small means like size-wise 2 centimeter?
Yeah, we measure right across the diameter,
Yeah,
and anything under 5 centimeters is considered small.
under 5 centimeter is small aneurysm.
Exactly. We do repair when the aneurysms reach 5.5 centimeters in men
Okay.
or 5 in women whose arteries tend to be a bit smaller.
Right.
Until then, from the time it's discovered until the time it reaches a size that would predict it should be repaired, we do surveillance. That might be once every
So
3 years.
ultrasound or checking,
Exactly.
scanning.
Ultrasound surveillance, and you use CT sometimes if it's difficult to see on
Sure,
ultrasound.
Sure. So the patient visits your office every 3 months, 6 months?
It could be every 2 years or 3 years, up to every 6 months as it gets to be
Okay.
a little bit larger.
Okay. And now somebody has aneurysm, say of size 4 centimeter. Do they have to change their lifestyle, like reduce the stress or anxiety or running around, or what are the lifestyle changes required?
Good question. Generally, under 5 centimeters, there's no restrictions on their activity, there's no restrictions on travel or driving, but it would be important to monitor it, to pursue smoking cessation, and to get good blood pressure control.
Correct. Now, somebody has a 5 centimeter, 5.5 centimeter aneurysm. What are the surgical options available for them?
There are open surgical and the minimally invasive, similar to the
Artery.
leg disease, arterial disease.
So when you say open surgery, what do you do?
So open surgery is, if you consider the old-fashioned way that we've always repaired them, it's an abdominal incision, clamping the aorta, which is behind the bowels, and actually suturing in a fabric graft in place of that aneurysmal tissue.
Okay.
It's a big surgery. There are people who might be frail who would not do well with that surgery because the risk of bleeding, the risk of heart attack, and the risk of other complications would be prohibitively high.
So what do they
So
have option then?
the other option is what's called an EVAR, or endovascular aortic repair. The first one was done in 1991, and they became common in the mid-90s. So we have about 20 years of experience.
So what happens in that? They put a graft or something? Or?
Exactly. So with an endovascular repair, we don't open the abdomen. Rather, we make small incisions in the groins and we access the femoral arteries. Through the femoral arteries, metal and fabric stent graft is advanced, and it's furled up like an umbrella inside a graft tube about the size of a pencil. So that fits easily through these arteries, and then under X-ray guidance we deploy the graft in pieces, and some of these pieces are detailed here, and it's all done from within the arteries through small incisions in the groins.
Is it a day surgery?
They stay usually 1 or 2 nights.
1 or 2 nights.
One or two
but
nights.
The open vascular surgery is like a
1 or 2 weeks.
2 weeks, yeah?
Yeah.
And after the surgery, the lifestyle is regular, or do you have to change? Or
We do surveillance, whether it's an open or an endovascular repair. We will keep an eye on the patient. You have your vascular surgeon for life at that point. But generally, after about 4 to 6 weeks, people resume their usual activities.
Now in Thunder Bay, I know you have started a new initiative for the vascular clinic. So can you please tell us about that?
Certainly. So in Thunder Bay, there are 3 vascular surgeons, myself, Dr. Rashid Osman, and Dr. Matt Ingvis, and we are out of the same office near the hospital. What we have done is instituted a rapid access to vascular evaluation clinic.
What is that?
And that is a way for primary care or other physicians, emergency physicians, nurse practitioners, to access us quickly if they think they have a patient who has an urgent concern. It may be a phone call, it might be a fax, but our office will book them into the next available slot, usually within a week of getting the referral.
That's very good. Nice initiative. So you can rapidly see the patient and treat them as quickly as possible.
As quickly as possible. Of course, patients who think there's a severe emergency should go to the emergency room and they will call us directly, but this is helpful as well.
Thank you so much, Dr. MacDonald, for coming to the show.
You're
We
very
really
welcome.
appreciate it. This is really helpful to everybody.
Thank you very much.
Thank you. Thank you, everyone, for being a part of the show.